Assalamualaikum. Hi, my name is Nikno Fahratu Akmal binti Nilokman. I want to present case study of premature rupture of membrane caused a 26 years old woman was diagnosed with candidiasis. Introduction. Premature rupture of the membrane PROM was a spontaneous rupture of the amniochorionic membrane prior to the onset of labor. PROM affect approximately 1 to 18% or even 31% of pregnancy. Etiology of PROM were diverse and are only known in about 40% of cases. Urinary tract and amniotic infection represent major risk factor in the occurrence of PROM. It also risks toward mother and the newborn of major consequence of PROM. This study aimed to identify the main bacteria involved in PROM and to evaluate their susceptibility to antibiotics in order to determine if the empiric antibiotic therapy. The most common infection that involved in PROM, which is Candida species. Candidiasis was also a fungal infection caused by yeast and also involved in premature rupture of membrane that belonged to the genus of Candida. Candidiasis in the vagina was commonly referred to as a yeast infection. At this case, from sample HSV get from patient to diagnose and must do the treatment to prevent the candidiasis infection towards PROM. PROM diagnosed based on a true clinical examination. Women with a history suggestive of spontaneous rupture of membranes, which is have sudden gush of fluid with continual leakage, who had a sterile speculum examination that demonstrate pooling of fluid in the posterior vaginal fornix, and called Tanya sign were considered PROM cases. Let's discuss. Case presentation. A 26 years old woman was diagnosed with premature rupture of membrane that was infected to the candidiasis with a medical history significant for pregnant women admitted at the ward with a gestational age greater or equal to 6 weeks of amenorrhea in the hospital. She had no complaint then. Prior to this time, while single, she had to induce abortion both at the gestational age of 8 weeks by dilation and curettage. A year prior to presentation, after her wedding, she had a spontaneous miscarriage at the gestational age of 16 weeks. This began with a spontaneous rupture of membrane, copious drainage of liquor, and painless passage of products of conception. At the presentation, cervical incompetence was suspected, and she was counseled for prophylactic cervical serrage, to which she consented. At 12 weeks, gestational age cervical serrage, which is treatment for cervical incompetence or insufficiency when the cervix starts to shorten and open too early during a pregnancy, causing either a late miscarriage or preterm birth, was inserted without any complication. She later presented at a gestational age of 23 weeks with a 2 history of copious drainage of liquor. Spontaneous rupture of membrane also confirmed with sterile speculum examination and ultrasonography. Then gestational age of 30 weeks, she felt lower abdominal heaviness and was given oral dexamethasone for meta-lung maturity, as we consider imminent established preterm labor within 48 hours. She was recommended on oral erythromycin for another 4 weeks and remained stable with clinical or laboratory evidence of infection, as evidenced by repeat positive culture of vaginal swab that was cultured on SDA agar that proved in the germ tube have infected by candidiasis, urine culture, and normal white blood cell count. Discussion. PROM was the condition in which the chorioamnion was distributed before the onset of labor. It was defined as rupture of membrane, which is breakage of amniotic sac, commonly called breaking of mother's water, more than 1 hour before the onset of labor. If rupture occurs before 37 weeks, it's called preterm premature rupture of membrane, PP-PROM, and the fetus and mother were a greater risk for complication. Premature rupture of the membrane provides a path for bacteria to enter the womb and puts both the mother and fetus at risk for life-threatening infection and also can cause death. Low level of fluid around the fetus also increase the risk of umbilical cord compression and can interfere with lung and body formation in early pregnancy. This is an example of ruptured amniotic sac of baby in the mother. Then diagnosis. The traditional minimal invasive gold standard for the diagnosis of PROM relies on clinician ability to document 3 clinical signs on sterile speculum examination, visual pooling of clear fluid in the posterior fornix of the vagina, or leakage of fluid from the cervical and alkaline pH of the cervicovaginal discharge, which is typically demonstrated by seeing whether the discharge turn yellow, nitrazine paper to blue, and microscopic furning of the cervicovaginal discharge on drying. On speculum examination, fluid draining from the cervix and pooling in the posterior vaginal fornix may be seen. Take sample HBS from vaginal swab to culture and sensitivity to get the positive or negative result. From this case, the result was positive. Yeast in the SDA agar after incubate in 1 day. Then, we continue with germ tube and move forward look under microscope time 40. The result was positively infected by Candidiasis. This is an example of running test that we can get result was positive then negative. After that, laboratory findings of hematology lab, we get result of full blood count, white blood cell height 40, RBC 4.07, hemoglobin low 11.3, hematocrit low 33.8, HemCV 83.0 FL, HemCH 27.8 Pg, then platelet 208. Then lab biochemistry, we find the result of urine FEME, specific gravity 1.015, pH 25, leukocyte 25, nitrite negative, protein 0.75, glucose normal, keton 5, bilirubin 17, erythrocyte 10, urobilinogen 17. Then renal profile RP of blood urea nitrogen low 1.37, sodium low 133.1, potassium also low 3.47, chloride 99.2, creatinine 555. Microbiology and serology lab, HBS culture and sensitivity, positive isolate with yeast infection that show the result of Candida species. Then virus screening or blood film or malaria or mycoplasma, which is negative. Sign and symptom: vaginal spotting and bleeding, increase in vaginal discharge, persistent contraction, painful or painless associated with cervical changes, intermittent abdominal cramping, pelvic pressure, and back ache. Conclusion and prevention: avoid sexual intercourse. A timely and accurate diagnosis of PROM was critical to optimize pregnancy outcome. Then provide to optimize prenatal outcome and minimize neonatal morbidity. Lastly, treat the antifungal medicine applied inside the vagina or a single dose of fluconazole taken by mouth. Thank you.